Hi, this is Dr. Shura Panini. The topic for today is diabetes and treatments of the modern era. The best way to describe diabetes is, simply put, it's a silent killer. Why control diabetes? Well, if it's not controlled, then you're risking both microvascular and macrovascular complications. Microvascular complications include retinopathy, the retina in your eye, nephropathy, which can affect your kidney function, neuropathy, which is your nerve function, and macrovascular complications include strokes, heart attacks, peripheral vascular disease, or claudication. There are two types of diabetes, type 1 and type 2. Type 1 is when you're not secreting any insulin due to your body attacking your pancreatic beta cells, so there's no endogenous production of insulin. Type 2 is when there's actually insulin resistance, preventing the insulin from efficiently acting on the cells to absorb glucose, so the receptors on the cells are not responding to insulin produced by the pancreatic beta cells. In type 1 diabetes, you need exogenous insulin to replace the lack of insulin. For the purpose of this presentation, we'll focus our energy on type 2 diabetes, old school and new school treatments. Metformin is considered to be the gold standard of type 2 diabetes treatment. It was initially discovered in the 1920s. It falls under a category of compounds called synthetic biguanides, and it wasn't really popular until the 1940s when French physician Jean Stern realized its potential to drop blood sugars and named it glucophage, or glucose eater. Metformin is an essential drug in the management of type 2 diabetes due to its properties: decreased metabolism of glycogen in the liver into glucose, increased uptake of glucose into tissues by increasing sensitivity to insulin, and decrease absorption of glucose into the gastrointestinal tract. Metformin is also used to treat insulin resistance in patients who have polycystic ovarian syndrome, gestational diabetes. Metformin is also used in patients who have polycystic ovarian syndrome, gestational diabetes, and in fact, there's mounting evidence that it also prolongs life. Patients sometimes do not tolerate metformin due to its effect on gastrointestinal tract, which can result in symptoms like bloating, nausea, diarrhea, and weight loss, along with lactic acidosis. Lactic acidosis is more common in patients who have advanced kidney disease, therefore it's contraindicated to use metformin in these type of patients. Another class of medications called sulfonylureas, for example glimepiride, glipizide, glyburide, which are commonly used in type 2 diabetes management, act by stimulating the pancreatic beta cells to produce more insulin, thereby decreasing the amount of glucose in your bloodstream. Sulfonylureas in general have received a lot of bad press. Although there's a significant amount of patients who continue to use and are prescribed sulfonylureas, we do understand as a medical community that these are not meant for long-term use due to studies previously published showing there's an increased risk of hypoglycemia, weight gain due to increased production of insulin by stimulating the beta cells, and eventually burning out the beta cells, therefore rendering it ineffective with prolonged use. The popularity of sulfonylureas is predominantly due to low cost, its easy to use mechanism, which is oral tablets, ideally taken once a day, sometimes twice a day, and its immediate effects on blood glucose levels by stimulating pancreas to produce insulin. Although the jury on whether to use sulfonylureas long term remains questionable, It's always important to talk to your physician or endocrinologist regarding benefits and risks when being prescribed sulfonylureas. Some quick background about GLP-1s or glucagon-like peptide analogs. It's categorized under a group of hormones called incretins. Incretin hormones were discovered by John Brown in the 1970s. Some approved medications under GLP-1s include Victoza, Ozempic, Bydureon, Saxenda, Byetta. All GLP-1s tend to come in as injectables, except for Rybelsus, which was approved in 2019 as an oral tablet. Incretin hormones like GIP and GLP-1 analogs act by stimulating pancreatic beta cells to produce more insulin and suppress alpha cells from producing glucagon, in effect decreasing blood glucose levels. GLP-1s are also shown to decrease gastric motility, therefore slowing down the breakdown of nutrition and decreasing postprandial blood sugars. Another class of medication to know about is a dipepto peptidase 4 inhibitor. This enzyme is actually responsible for breaking down GLP-1. So by inhibiting this enzyme, we subsequently increase the levels of GLP-1, which results in decrease in blood sugars. Some examples of DDP4 inhibitors include sitagliptin, like Januvia, saxagliptin, Onglyza, linagliptin, Tradjenta, alogliptin. Just remember the extension gliptin. Another new class of medications called Sglt2 inhibitors, which stands for sodium glucose link transporter 2 inhibitors. Examples include Farxiga, dapagliflozin, Invokana, canagliflozin, Jardiance, empagliflozin. Just look for the extension gliflozin. These medications act by blocking the Sglt2 receptors on the proximal tubules in your kidneys, thereby excreting glucose into the urine. Data clearly suggests use of newer diabetes medications like GLP-1s, DDP4 inhibitors, and Sglt2 medications can be very effective in patients who have uncontrolled diabetes, who are already taking Metformin and can benefit from some of the newer medications. Adding GLP-1 to a person who has uncontrolled diabetes with A1C greater than 9 can result in 0.6 to 1.9% A1C reduction when taken with Metformin. Compared to Sglt2, there could be somewhere between 0.5 to 1% reduction in their A1C. And with DDP4 inhibitors, similarly 0.5 to 1% reduction in A1C. Some important adverse reactions to be aware of when using GLP-1s is to not combine GLPs with insulin or sulfonylureas like glipizide due to risk of drop in blood sugars or hypoglycemia. With DDP4 inhibitors, there is increased propensity for infections like common colds or upper respiratory or UTI type of infections, and can also have side effects like hypoglycemia when you combine with insulin, sulfonylureas. Also, rarely acute pancreatitis, anaphylactic reactions, and skin rashes like Stevens-Johnson syndrome have been reported. Adverse infections and events noted with Sglt2 inhibitors include UTIs, yeast infections, general infections like Fournier's gangrene, which is a flesh-eating general infection, and lactic acidosis, ketoacidosis. Lactic acidosis could be more profound with medications like Metformin, which also increases risk of lactic acidosis. I want to draw your attention to Invokana, which is canagliflozin, which is an Sglt2 inhibitor, has been associated with adverse events like risk of leg amputations or foot amputations, along with kidney injury and urogenital infections. So FDA has issued a stronger warning about this risk related to Invokana. Another Sglt2 inhibitor, pioglitazone or Actos, has an FDA warning due to its association with increased risk of bladder cancer and should not be used in patients who have bladder cancer or symptoms suggestive of bladder cancer. Dr. McMurray and his colleagues did a study in UK looking at use of dapagliflozin in patients with heart failure and reduced ejection fraction, and studied their outcomes basically with the use of a diabetes drug. And what they found was really interesting. Both patient groups, diabetes and non-diabetic patients, benefited with the use of dapagliflozin. Essentially, dapagliflozin showed that there was improved outcomes in patients with heart failure, despite of having diabetes or not. And it's postulated this benefit is due to possibly preventing deterioration of kidney function or improving diuresis in patients with heart failure, and also decreasing glucose levels, which may indirectly affect the heart and improve heart's efficiency. Some takeaway points for our presentation include remembering control of diabetes can save you from significant mortality and morbidity. Goal A1C should be less than 6.5. If you have uncontrolled diabetes, talk to your doctor about adding some of the newer medications that we talked about, like the GLP, SGLT2, DDP4 medications.